So let's get started. Welcome everybody to the August edition of the CMR Journal Club. We have, I'm Matthias Friedrich, and welcoming you from Montreal today. We have two very interesting and especially very clinically relevant papers on stress cardiac MR. And stress perfusion has, I think, reached clinical maturity after lots of studies, lots of good data showing that it's obviously better than many other techniques, including nuclear, in terms of accuracy, but also in terms of cost efficiency, safety, and so forth. So it's now then the time to, of course, look at let's say clinical implications or applications in diseases that are not necessarily coronary artery disease. And then also it's always good to look out what's happening on the horizon, new methods. So what we have today are two papers. One is on stress CMR in patients with moderate to severe aortic valve stenosis. So that's mainly a question about, is it safe to do that in the first place there? And the second paper then from Jannike and Nickander from Stockholm will be on mapping used in the stress scenario. So let's start with Janek Salatzki from the University of Heidelberg and his paper titled Safety of Stress Cardiac Magnetic Resonance in Patients with Moderate to Severe Aortic Valve Stenosis, and published in the Journal of Cardiovascular Imaging a few months ago. Janek, take it from here.
Thank you, Matthias, for the introduction. I'm very humbled to present our clinical work here in your journal club. In the clinical practice, we are frequently encountering patients who suffer from a significant coronary artery disease as well as from a relevant aortic valve stenosis. It is well established in the guidelines. You might already know that patients before a valve surgery or transcatheter aortic valve replacement are required to undergo an invasive coronary angiography if they have a high pretest probability for significant coronary artery disease. However, for testing the functional significance of coronary artery disease, we have, in order to plan for possible PCI or coronary artery bypass grafting, there are stress tests available. However, adenosine perfusion stress tests or dobutamine stress CMR are still relatively or absolute contraindicated in patients who suffer from severe aortic valve stenosis. Therefore, we, and due to the lack of current data, we conducted the study where we looked at the incidence of adverse effects in patients with moderate to severe aortic valve stenosis undergoing dobutamine or adenosine stress CMR. We performed this study here in Heidelberg, and we conducted retrospectively data from our database from between January 2009 to December 2021. Patients were evaluated in terms of the aortic valve stenosis using echocardiography. We collected data on the cardiovascular risk factors as well as the comorbidities, as well as cardiac biomarkers. Adverse events were subdivided into severe, non-severe complications, as well as minor symptoms, which were primarily looked at chest pain, as well as dyspnea, nausea, or pain besides chest pain. So from the database of which consisted of approximately 25,000 patients, we could identify 187 patients for the study. 92 patients underwent a stress CMR using adenosine, and 95 patients underwent stress CMR using dobutamine. Now, looking at the results here in table 1, you can see that here from the baseline characteristics, you can see that this was a quite large cohort with 76 years in mean in the adenosine group and 75 years old in the dobutamine group. They were predominantly male with more than 80%, and they were predominantly symptomatic with a New Year stage of 2. The main cardiovascular risk factors were hypertension in both groups with 90% approximately, and hypercholesteremia, which with sort of 70%. As expected, the majority of patients suffer from coronary artery disease. And compared to the control group that we also established, that you can see here in the right column to the patient group, in the adenosine group and in the dobutamine group, we could see that the cardiac biomarkers, in particular NT-proBNP, were significantly elevated, mainly due to the increased pressure overload in patients with severe or moderate aortic valve stenosis. In particular, in the group who underwent dobutamine stress CMR, there was also troponin T elevated compared to the controls. The left ventricular ejection fraction was similar compared to the controls, but the left ventricular antiastolic volume was increased compared to the controls in both groups, also predominantly due to the higher pressure overload caused by the valve stenosis. We could identify, or we could find 28 patients in the adenosine group who suffered from a severe aortic valve stenosis, and 18 patients who suffered in the dobutamine group suffered from a severe aortic valve stenosis. Now looking at our results in terms of frequency of complications and minor symptoms, there were no severe complications that we found in both groups, which were, for example, divided as death, myocardial infarction, STEMI, and STEMI, or hospitalization. There were, however, some minor symptoms as well as some non-severe complications. There was only one patient in the adenosine group that actually suffered from a minor symptoms, which were severe chest pain, as well as from a non-severe complication, which was a third-degree AV block. This test also had to be stopped immediately due to the complication. In the dobutamine group, there were 19 patients who actually suffered from complications or minor symptoms, predominantly minor symptoms, in particular chest pain. 5 patients experienced non-severe complications. In particular, 2 patients experienced atrial fibrillation, 1 patient experienced supraventricular tachycardia, and 1 patient each a decrease in systolic blood pressure, or 1 patient in significant increase in systolic blood pressure. 3 stress tests actually had to be stopped due to complications, which were primarily in 2 patients chest pain and paroxysmal atrial fibrillation in the 3rd patient. Now, as you may appreciate, the majority of complications occurred in dobutamine stress group. That's why we looked at risk factors that might cause the complications. And we will look at table 3 now. So you can see here the comparison between patients who suffered from complications or minor symptoms doing dobutamine stress CMR compared to patients who did not suffer from any complications or minor symptoms. The cohort with complication was significantly older, with a mean age of 80 years old, suffered more often from hypercholesteremia, and had a higher prevalence of coronary artery bypass grafts, as well as prior strokes compared to the patients who did not experience any complications. I also had significant higher troponin T values, and interestingly, they revealed more often positive stress CMR results, so they showed significantly more often an inducible ischemia. Interestingly, the area of the aortic valve stenosis was similar in both groups. Now, we also wanted to identify, we also correlated the occurrence of complications and minor symptoms in the dobutamine stress CMR. We could see that age, hypercholesteremia, prior stroke, prior bypass grafts, as well as inducible ischemia correlated moderately to the occurrence of complications. Using univariable analysis as well as 2 multivariable analysis models, we could see that age, hypercholesteremia, prior bypass grafts, as well as prior strokes and inducible ischemia were associated with the occurrence of complications and minor symptoms, and that age, prior coronary artery bypass grafts, prior strokes, and inducible ischemia were independently associated with the occurrence of complications. Now, in our discussion, sorry, it's the wrong way. In our discussion, we highlight the importance of dobutamine stress CMR as well as adenosine stress CMR in order to identify significant coronary artery disease and the importance of these two tests in terms of all-cause mortality, cardiac death, and myocardial infarction. So the prognostic value of those tests. We compared our results to the literature, and we could see that they were actually similar compared to larger studies who did not include patients with severe aortic valve stenosis, in particular in terms of the incidence of atrial fibrillation, a drop of systolic blood pressure, an increase in systolic blood pressure, and the transient AV blocks. It needs to be highlighted that also from the literature, sorry, we go to the last page here, that severe complications, including death during dobutamine stress, are actually very rare, and the expected significant drop in blood pressure in the adenosine stress was not observed in our study. We expected that due to the adenosine and the vasodilative effect and the high pressure gradient caused by the significant aortic valve stenosis, that those patients suffered from a higher incidence of a blood pressure drop. This was not the case. In our idea of developing a risk stratification model, we could find that an older population with severe vascular disease and inducible myocardial ischemia seems to be at higher risk for complications doing dobutamine stress CMR. It needs to be obviously highlighted as this study suffers from limitations due to the retrospective nature and the quite small sample size of just 187 patients, and also patients who suffered from a severe aortic valve stenosis below an area of 1.0 square centimeters were quite limited. However, major complications seemed unlikely in stress CMR performed in this high-risk cohort. As a summary, stress CMR for ruling out inducible ischemia appears to be safe according to our results in patients with moderate to severe aortic valve stenosis. However, age and prior coronary artery bypass grafts, prior strokes, and inducible ischemia are independent variables associated with adverse events. And adenosine stress CMR was associated with significant fewer complications and minor symptoms than dobutamine stress CMR in this high-risk group. Thank you for your attention.
Thank you very much, Jannik. I forgot to mention initially that I'm also involved in the research in Heidelberg, so I'm a co-author here. But I will definitely not have that any impact on questions and such. So if you have questions, as usual, please everybody put it in the chat or just unmute yourself. Can you talk a little bit about the setting, because for some people it may be surprising that you just do that routinely and even do a retrospective study later. Can you talk a little bit about the setting in Heidelberg, how your experience generally is with cardiac MR in patients who are sort of unstable, be it on an ischemic level or heart failure, or in this case, severe valve disease. So is this routine, and what is your experience with that? You do yourself a lot of clinical CMR scanning. So can you talk about that a little bit?
Yes, thank you, Matthias. So the question comes up quite routinely in patients who come from the outpatient unit to us, or who are referred to us with a severe aortic valve stenosis. We perform coronary angiography, and then quite often when we see a 50 or 75% stenosis, we are not quite sure about the relevance, and we want to, in particular, send the right patient into the right path, so for TAVI or for surgery. We perform stress tests quite often. We are well experienced with this high group. We have a great team of MR technicians who are very mature and have lots of experience with older patients who suffer from significant free vessel disease on top of the severe aortic valve stenosis. In terms of the test itself, we observed that those patients suffer quite more often from chest pain. So that was our observation in the clinical routine, and that's why we conducted the study, which sort of was not really objectable.
So is it fair to say that for the team there, getting a patient with, let's say, moderate to severe aortic valve stenosis or with heart failure for adenosine test would not stress anybody there from the team?
Yes, absolutely.
Okay.
Yeah.
So I think this is a very important message from this paper and also from what you say, because there's definitely a lot of angst out there. People are concerned about the safety. It's also my experience in other places like here in Montreal or in Calgary or in Berlin for that matter, that the adenosine test is really very safe, even in people where you are otherwise concerned. So I would definitely be more relaxed than putting someone on a treadmill or on a bike. There are two questions and with a request for a brief answer. One is, did you also look at the diagnostic accuracy of the tests in terms of all the accuracy markers and maybe a standard such as invasive angio with FFR?
So in this study, we did not look at FFR measurements, unfortunately, so we could not compare the positive stress results with the actual gold standard FFR. We perform FFR routinely at our center. However, we know from other studies that adenosine stress test is quite good as well, and is comparable, absolutely comparable with compared to FFR measurements. However, you are absolutely right. In this particular cohort with severe pressure overload in the left ventricle, one can presume that an inducible ischemia might not be only caused by a significant coronary artery disease, but also by the high pressure in the left ventricle. So we should look into that in further studies. Absolutely right, yeah.
And the other question is, what is the deal between cardiology and radiology here? Because you're with cardiology and the scanners are basically hosted by cardiology, but can you comment on that? Yes,
so the scanners, they belong to the cardiology department. However, there are more and more rotations and young fellows that are coming in from the radiology department who learn CMR from actually the cardiology department. So I think it's the other way around. We have a quite long history in Heidelberg for this, that cardiology is running the CMR. However, there's always a close connection with the radiology department, and we are in close contact with them if there are any additional questions, in particular outside of the heart. So we are just focusing on the function of the heart and the evaluation of ischemia. Yeah.
Okay, thank you very much. Jannik, if you could unscreen or unshare your screen. And then Jannike, welcome. Jannik is from the Karolinska Institute in Stockholm, does a lot of great research and will present her paper today on the use of stress native T1 and native T2 mapping. This is particularly interesting. There was a previous report on T1 mapping with stress that had to be retracted. So the field got a little bit nervous, and I think that's that's excellent that we have now another completely independent study on that topic. So Jannike, very much looking forward to your presentation.
Well, thank you, Matthias, for the invitation. Also, thank you for the presentation. And I agree with your introduction there that this is important. And so what we did in this study is that we looked at stress native T1 mapping and T2 mapping compared to myocardial perfusion reserve in the long-term follow-up of patients with severe COVID-19. And as you know, severe COVID-19 may cause a cascade of cardiovascular complications beyond the viral pneumonia. And the severe inflammation may affect the microcirculation, which can be assessed by cardiovascular magnetic resonance imaging using quantitative perfusion mapping. And native T1 and T2 mapping has previously been shown to identify the changes in myocardial perfusion by the change in native T1 and T2 during adenosine stress. But just what Matthias just said, that in 2018, there was a JACC paper that showed superior diagnostic performance for stress native T1 mapping compared to contrast techniques that was later on retracted. And for us, it's been very important then to put forward data on how native T1 and T2 behaves under adenosine stress, especially then with regards to myocardial perfusion reserve for diagnostic purposes in different clinical populations. So the relationship between native T1, native T2, and then the changes delta T1 and delta T2 with myocardial perfusion reserve and myocardial perfusion in severe COVID-19, it was currently unknown. So that's why we deployed the study. And in the study, we prospectively included patients hospitalized at Karolinska due to severe COVID-19. They underwent CMR at 1.5 T during long-term follow-up between November 2020 and September 2021. And they were eligible to be included in this big follow-up study if they were discharged from the hospital at the intensive care unit or hospital wards for severe COVID-19, which then was defined as a respiratory failure with a high demand of ventilatory support or oxygen. So you needed to have at least 5 liters per minute of oxygen flow rate. But most of these patients were situated in the intensive care unit. And this is the imaging protocol, sorry. So what we did was we acquired skeleton cities, and then we did our native T1 and T2 at rest. We then started our adenosine stress infusion, and we did stress native T1 and T2 mapping after 3 minutes, and then we did a perfusion map. And we stopped, and then we waited, and then we did the rest map, and then we did post-contrast T1 for extracellular volume and also late gadolinium enhancement. And this is just the basis to show how we segmented the images. So this is in panel A, you see the stress perfusion, in panel B, you see the rest perfusion, and C native T1 and D native T2. And what we did then was that in total, there were 37 patients that underwent adenosine stress CMR, and they underwent the scan 292 days following discharge. And we could see minimal scarring, like gadolinium enhancement, in 4 patients, and they were included in all analysis because of the limited extent of the scarring. And then I'm thinking we're going to just walk through some of the baseline characteristics and then jump into the comparison of the perfusion and native T1. So these were our 37 patients. There were 9 females. They were 57 years old. And their top troponin level was 51 during hospital stay. Those who had an elevated pulmonary artery pressure, there was the median of 50, and previous medical history. So 1 patient had diabetes, 1 had atrial fibrillation, there was no patients with hypertension, and 1 patient had pulmonary embolism during the hospital stay. And looking at the heart, so end diastolic volume, they were not severely dilated. The stroke volume was good. The ejection fraction was 55, so normal or just below normal, and normal extracellular volume. And as I mentioned, there was some scarring in 4 patients. And then for our mappings, so the native T1 and native T2 were all within normal ranges. And then the stress native T1 and T2 comparable with what we have published before in normal physiology, and no difference actually in the delta T1 or delta T2. And then looking at the perfusion, we can see that overall the stress perfusion was within normal range and a normal MPR. And within this paper, there are several tables where you can look at the different associations between native T1 and T2 at rest and stress compared to perfusion values. But I think this is the most important one to highlight, this figure, figure 3. So on the vertical axis, we see native T1, and on the horizontal axis, we see myocardial perfusion. We have in white rest values and in black stress values. And looking at the pooled correlation here, we see an R-square of 0.35. And on the right panel, you see native T1 on the vertical axis and myocardial perfusion on the horizontal axis. And then once again, rest in white and stress in black, and an R-square of 0.28. And these are somewhat comparable to what we've published before in normal physiology as well. And then I think we're going to walk down to table number 5, which is then all the separate values correlated with myocardial perfusion reserve. So not the absolute perfusion, but the reserve. And as you can see, so neither native T1 at rest, T2 or T1 at stress, T2 rest, or T2 stress, or the changes, the deltas, have any correlation with the myocardial perfusion reserve at all. And there have been some previous studies where they've been an association, especially with native T1 at rest, as an increase in patients with aortic stenosis, that you have an increased congestion within the heart to an increased native T1, which then has been correlated with the perfusion reserve. And that's also interesting in thinking of the different endotypes with regards to coronary microvascular dysfunction, that if you have a high demand for with your rest perfusion, your native T1 will increase, and then can that be correlated with the myocardial perfusion reserve? But we could not show any of that in this data. So with that, we conclude that native T1 and T2 do correlate with myocardial perfusion during adenosine stress, which most likely reflects the coronary circulation in patients during long-term follow-up of severe COVID-19. But delta T1, the changes, delta T1 or delta T2 can be used to assess myocardial perfusion reserve in patients with severe COVID-19.
Yeah, thank you very much. So again, whoever has questions, please post it. So so the conclusion here for some, it may sound like on one hand you say native T1, native T2 correlate with perfusion during stress, but the delta is not really useful. So what you're seeing is that the change during stress, there is a change, but it doesn't really reflect perfusion. It must be something else. Is that what you're concluding from that in terms of the physiology?
Well, it's really difficult because they're also like I've seen like two sides now with regards to, should we do stress only and do quantitative stress perfusion, or should we do the MPR and really look at that? So MPR is what we've had, and like MPR index with our non-quantitative techniques. So there's a lot of literature on MPR, which I think is a very strong predictor. But there's also more and more data coming out on stress only, and then just using myocardial perfusion, the absolute perfusion, for diagnosis, both for microvascular dysfunction, but also obstructive coronary artery disease. So I would say that using non-contrast techniques such as native T1 and T2 for diagnosis of obstructive coronary artery disease is highly unlikely, but it does somehow show the changes that happen in the coronary vasculature, but it could never be used for diagnostic purposes.
Mm-hmm. And again, so because I think the underlying physiology would be very important to understand. So while T2 is quite specific for water content and therefore can be used for edema, that has been shown, especially by the group in Vienna, to be a marker for or related to myocardial edema in heart failure, for example. Native T1 also is dependent or can also be increased by edema, but also is increased with any other cause of an increased extracellular volume. So the relationship with the perfusion, to me, it's something I do not have an answer for yet. So why do we expect an increased T1 and T2, which could be edema, to be correlated with a better perfusion, a higher perfusion? Or is it just, does this become then a confounder that way they have a basically increased water content, and therefore the perfusion results are also quote unquote false high? Or do you think that's too wild of an?
Yeah, no, so this is what we've been struggling with. And also my former supervisor, Professor Martin Nickander, we had, hard discussions on which is what. So for me right now, which is, still speculation, it's also hard to prove. But for me, I think how I envision the physiology. So the increase in blood volume with adenosine increases also the amount of plasma in the myocardium, and it's the plasma with the high signal as opposed to the iron, or like our red blood cells with the HP. So that with the hemoglobin, it's the increase in plasma that is what we're capturing with the native T1 and T2 due to the higher signal. So is it edema? No, it's not edema. It's the increase in myocardial blood volume, and especially the part which is plasma, which gives the signal. That's what I think physiologically that's happening. And that's also based on the data we did in our normal physiology with stress extracellular volume. So the increase that we could see in extracellular volume, I would think that it's because of the plasma. I can't prove it. It's a speculation, but that's what I think. And I don't know, but I don't think that the myocardium in itself swells during, or like has edema during stress tests.
I mean, we are dealing with patients after COVID, so it could be that there is a mild chronic inflammatory component here. We know that some papers have suggested that, and this was almost a year thereafter, so it may not be coming from, it would not be the first thing. But another aspect could be that if patients have, let's say, impaired perfusion, what the system does is it goes more to vasodilation to basically provide always the best blood flow to the periphery. And so there may be a kind of a status of permanent, slightly dilated coronary artery periphery that may be a confounder here. Okay, I see there's a question saying there appear to be trends towards lower myocardial perfusion at stress and MPR in the study cohort. Is this a real difference, not demonstrated because of a small sample, or was there enough power to show no true long-term detectable cardiac finding from severe COVID-19?
Well, so this is actually a question we have. This is a manuscript in under review right now. So yes, there was a difference between the controls and the patients with severe COVID-19, and also with sex and age match controls. So the COVID-19 patients at follow-up have lower perfusion. Yes. And also that those that still experienced a lot of chest pain had a lower myocardial perfusion reserve compared to the COVID-19 patients that did not have. And there's also interesting data. I'm not sure that it was presented at the CMR in San Diego from Northwestern, where they also looked at those who had long COVID. And what you were talking about before with the higher resting, the increase in rest perfusion, that the patients with the post-acute sequelae of COVID-19 had this specifically, that the rest perfusion is increased, and then the myocardial perfusion reserve is reduced due to the fact that the bottom line is increased, which is likely, like you're saying, there's an inflammation or something that increases the need for that you have a vasodilation at rest.
Okay, thank you very much. So I think this is very interesting, and there are also comments that this is exciting work. So if you could unshare your screen, I want to thank both of you, Jannik and Jannike, for the very clear and informative presentation. So before I let you go, I just want to point you to a journal club, which will be unusually not in the first week of September because of a conflicting meeting, the European Heart meeting. So it will be on August 30, and it has been put together by Nicole Seiberlich. She may be on vacation, so I may be the one who will moderate the papers. So it's about CMR 7 Tesla, which was always a big challenge, and we will find out whether it's still a challenge. So I hope you can join then. Otherwise, again, thanks to the presenters, and thanks everybody for joining. Wish you all the best, and see you next time. Bye-bye.